Welcome to the session. In this session, our speakers will examine innovative strategies for proactively addressing housing and support services, the role of state Medicaid programs in housing assistance, the role of effective local partnerships in managing this crisis, and more. Before we dive in, we'd like to thank the sponsor of this session, Commonwealth Care Alliance. Based in Boston, Commonwealth Care Alliance is a not-for-profit integrated care system influencing innovative models of complex care nationwide. Mission-based and person-centered, CCA is singularly focused on sustainable and evidence-based healthcare breakthroughs that fill important gaps in care and improve the health and well-being of people with significant needs. This includes advocating for affordable, high-quality, and cost-effective healthcare policies that lead to healthcare equity for the individuals who need it most. It's my pleasure to introduce the moderator of this session, Dr. Robert MacArthur, Chief Medical Officer of Commonwealth Care Alliance. Dr. MacArthur, the floor is yours.
Thank you, Maria. I appreciate the opportunity to talk today about one of the key areas of social determinants of health. What does that mean? Social determinants of health are non-medical factors that influence health outcomes. The World Health Organization estimates that 30 to 55% of health outcomes are actually completely controlled and influenced by these non-medical factors or social determinants of health. We at CCA are committed and have been for many decades to addressing individual social needs and making sure that those things are addressed before we address their medical issues. It's a cornerstone to the work we do. We take ownership for it. It's not somebody else's priority. So we think it's a critical component to having people achieving the wellness that they desire. And as an example, we're going to show a video here of some of the work that we've done in Boston related to housing.
Commonwealth Care Alliance is a multi-state integrated care system that has earned national recognition for its expertise in complex care coordination and delivery, improving health and quality outcomes while lowering overall costs of care. Today, CCA is supporting low-threshold housing for chronically homeless individuals. In 2021, Governor Baker and the Secretary of Health and Human Services in Massachusetts asked our help in dealing with the crisis of opioid and other substance use disorders, resulting in homelessness in Boston. The goal: provide residents at one of the city's homeless encampments a safe and secure place to receive medical treatment, peer counseling, substance use recovery, and a pathway to permanent housing. We responded by helping to develop a temporary housing community, a first-of-its-kind non-congregate solution on the East Coast. We're collaborating with the state, the City of Boston, and its mayor to erect and manage this self-contained community of 18 specially designed and equipped cottages. Here at the cottages, CCA deploys its proven clinical model of uncommon care to provide and coordinate a full range of services on site: 24/7 medical care, nursing care, social services, housing assistance, and behavioral health care, including psychiatry.
One of the biggest things about this community is the harm reduction model, and every single cottage has a harm reduction kit, which is very important. It's a way of stopping the cycle and the transmission of diseases and other things that come along, unfortunately, with substance use.
Our recovery coaches are key to this program. Many of these folks have complex long-term substance use histories, and the recovery coaches can support them in the community as well as here in the cottages.
The cottages feature a community room where CCA staff hold group sessions with the residents.
Many of our members have been on the streets for so long that the idea of moving into permanent housing causes them great anxiety. We ensure that they have those same consistent services when they move into permanent housing.
The most important part for me is definitely having a key place that I know I can go that night, not having to leave in the morning, and having a place to fall back. I can leave my stuff there and it's going to be safe, and also being around other people that are in the same situation.
We want to increase engagement. We have planter boxes up and down the community, and there has been a high level of interest from our residents and team to be part of the planting in those.
CCA staff puts a high priority on building trusting relationships and fostering a culture of support, respect, and mutual safety.
This is truly a community of peers. We've had people that have moved on to permanent housing, and they've asked if they could come back and run a group. I think it's incredible that they feel that level of connection to this community.
The complexity of substance use disorders and resulting homelessness is afflicting so many cities today. CCA is proud to be pioneering a solution that could be extended throughout the country.
It's incredibly important to see the value in this comprehensive model and the results that we have seen in a very, very short time.
Transforming the nation's healthcare for people with significant needs. That's Uncommon Care. That's Commonwealth Care Alliance.
Well, thanks. That's an inspirational video for all of us to see what actually can be done. And I'm so happy today to be joined by three panelists who are very much experts in addressing how housing affects healthcare in the United States. We have folks from a local level, regional level, and national level to provide appropriate perspective and commentary. We'll start with introductions. First, Korvachei Hernandez is the Director of Community Health and Social Determinants of Health program at CCA. Korvachei has more than 15 years of experience supporting individuals and community-based organizations in addressing social determinant of health needs. Korvachei has also been instrumental in developing the CCA Community Health Worker program. Second, Kathy Moses is a senior fellow at the Center for Healthcare Strategies. She works with the state Medicaid agencies on initiatives aimed at improving quality of care for people with complex needs. Her expertise is in care management, supportive housing, physical and behavioral health integration, and quality improvement for individuals with complex needs. And we also are joined by Keith Wales, who is the Director of Homeless and Outreach Services at Eliot Community Human Services. He has over 20 years of project management, leadership, and clinical expertise, and is passionate about building and scaling sustainable trauma-informed multidisciplinary continuums of care to support newly housed individuals through the lifespan. So that will start with some of our questions today. First question is, how does housing impact health, and what specific aspect of housing impacts health the most? And so Korvachei, we'll start with you. Maybe comment on housing insecurity.
First of all, let me say thank you to Modern Health and also to you, Dr. MacArthur, for the opportunity of just having this critical conversation around housing in healthcare. I like to start with the basics. I think it is well established that social unmet needs become those drivers of health. And these are the priorities that often are dictating what patients and members categorize as pressing needs. This is also what Maslow's hierarchy of needs philosophy establishes. And if the most fundamental basic needs of individuals are unmet, it is extremely difficult to really engage on healthcare conversation. And I know this might sound as basic information, and perhaps it is. But it is important not to miss this basic foundation when we're trying to address housing insecurity, especially in innovative ways. Social determinants of health and housing insecurity in particular becomes this driver of health and becomes a priority in a person's life, a priority over their health, their medication regimen, PCP engagement, etc. But it also implies a stress that is associated when someone has a housing insecurity need. It only exacerbates medical conditions. This is why I believe that in healthcare, we need to be able to assess holistically, even if it means at a very superficial level, but really to allow us to capture any underlying unmet social needs. Driving, frequent inpatient hospitalization, also many of the ED presentation that may or may not end up in an admission, but nevertheless, it is impacting a person's health and well-being. I think it is important to also have a clear understanding of how housing impacts health and well-being of individuals. Also, knowing that semantics matters when it comes to this topic of housing. A great number of patients in the state of Massachusetts and nationwide are impacted by housing insecurity or homelessness, which means that housing is already in healthcare. So we might as well begin to assess and provide the right level of support for patients facing housing insecurity.
Thank you, Kobe. If we sort of take it to the next level and we think about, how is homelessness impacting people's access to achieving the wellness that they want? And Keith, maybe you can speak to that for us.
Sure, I'd be happy to. There are a constellation of barriers that sheltered and unsheltered homelessness brings, namely accessibility to transportation. What do I do with my possessions? Where do I leave them? Do I have enough minutes on my phone? Where am I going to eat? Navigating the, potentially tumultuous weather. And legal issues. There are a number of things that make not only attending appointments challenging, but actually engaging in the substantive treatment that providers have to offer. So one statistic that I want to point out that illustrates how compelling transitional and/or permanent housing can be is 85% of cottage residents had their healthcare needs managed by Boston Healthcare for the Homeless, which engages in street medicine. And right now, 61% of the 85% have actually transitioned their care over to community-based providers after receiving transitional stabilization support services at the cottages and other sites. And this has been amazing to see that progress in that realm.
Thanks, Keith. Kathy, what sort of supporting services are available to help keep people in their homes?
Great, thanks so much, Rob. I just wanted to share, about the supporting services that, we know we're preaching to the choir, but that housing is healthcare for folks, and that, we've heard from both Kobe and Keith about an individual's basic needs and the importance of or the realizing that homelessness adds such an additional level of complexity for a person's health. But I wanted to skip over both of those and talk about supporting services such that, once someone is actually housed, that's not the end of the road. And so I want to share a story first in my comments here, because I think it's really poignant and important to think about the fact that housing isn't a one-time fix. So I was at a meeting where a person was speaking as the keynote speaker who had a previous experience of lived experience of homelessness, and was also working for the homeless service organization that had provided her services. And she said, the biggest mistake that folks make is they think, okay, great, I've connected someone to housing. They're off my to-do list. Everything's okay. And that's not really the case, and in her words, people are still struggling with, interpersonal relationships that are important to build, for example, with a landlord, or finding the money for a first month's rent, having the skills needed just to function in a housing environment. And so, her words were, you think this is a win, but we may end up back out on the streets if we don't have the supporting services that we need. And so those can include, anything from, again, money to pay a deposit, skill building to, work with others and to manage a timeline and working on, paying rent on time, other supporting services like counseling and, having quick and easy access to medical care that's not, again, 3 bus stops away. And so I just wanted to share those as some of the supporting services that once someone's in housing, that need to continue to wrap around them in order to keep them there.
It's super important, Kathy, to just, it's not achieving housing. It's not a one-time venture. It's a lifelong exercise in providing people appropriate support. So it's tremendous commentary there. What are some of the healthcare needs of people who are homeless or housing insecure? Kathy, maybe you could comment on mental health or substance use needs.
Yeah, absolutely. So I think it's important to think about a variety of healthcare needs. The 3 of us are going to touch on a couple of different ones today. But mental health care needs along with substance use needs taken together, we kind of, call those behavioral health needs all together. And people who are experiencing homelessness have 40% of them, if not more, have a known either mental health or substance use need. And so being able to get creative about how to meet people where they are to meet these needs are very important. I think about things like medical respite programs, where people who, kind of the tagline to medical respite homes are people who are not quite sick enough to stay in the hospital, but not quite well enough to return to the street. And so, behavioral health concerns and conditions can certainly be the types of conditions that can, be treated by someone having access to medical respite, or programs such as sobering centers or alcohol management programs. Within a housing first context that allow people to have some of their behavioral health needs met while they are homeless, which isn't the same for you or I, who, are already have a home and are able to seek that care in a different way. Now, I do want to share that through COVID, one of the things that kind of silver lining, I suppose, is this acceleration of behavioral healthcare innovations, such as using telehealth. And so while we realize that, that is an innovation that doesn't always work for people experiencing homelessness, it is something that I think folks have had some success with across states, across our country, in terms of looking at the opportunities to either give folks phones or have them come into a clinic or another place, safe place where they can make a phone call and have a telehealth visit. And so I know we'll talk more about that across the 3 panelists, but just really want to lift that up, that COVID has been, of course, a terrible challenge, and is definitely a crisis on top of a crisis for people experiencing homelessness. But that, to the degree we're able to think about what some of those innovations are to help address some of their healthcare needs, like behavioral health needs, it's really helpful.
Yeah, I think that's definitely one of the silver linings of COVID, is we've been able to advance the use of some technology to support individuals sort of across the healthcare continuum. So with that, Kobe, could you speak a little bit about specialized services that remove barriers for folks?
Sure, and thank you, Rob. Let me first just make a comment or two about something that Kathy just mentioned, and it's how the pandemic really created just ways for innovation and collaborative work to really address this and many other patients' social needs. And as the states now begins to return to some type of normalcy, I think it would be good to just continue to enhance and promote and even advocate for the continuation of those innovative collaboration, because it only benefit patients and members. I wanted to touch a little bit about the barriers around housing insecurity, and I'm going to steal a quote from Kathy that she just talked about. The end goal is not just finding a place to live for an individual, for the various reasons that Kathy just shared with us. And when that becomes the end goal, then what we often see is an endless cycle of patients going from being housed to insecure to homeless. And this is because behind every housing insecure patient, there's a story, and that story highlights the barriers, the reasons why they are in such condition. So I feel like, first of all, we need to do our due diligence to understand what those barriers are. Is it related to rent payment? Is it that the patient is paying a higher amount from what they can afford? Is it a cognitive, physical impairment that is preventing that patient from making this monthly payment? Is it a language barrier? I think we get the point that we cannot really implement effective interventions if we don't understand the barriers in the first place. I think for us here at CCA, if we were to work with members facing some of the barriers that I just alluded, I think, some of the intervention we will put in place is, we will connect this patient with rental assistance program, or we will provide education around more affordable housing options. And I'm going to come back to that in a moment. Or, we will look at is there a need for a repayee to come and help that patient to manage their monthly payments? I think another aspect when it comes to housing insecurity that is important to highlight is related to reasonable accommodations and how this directly impacts a patient's health and subsequently also increases utilization. Think about for a moment about patients with mobility devices, living at a place with limited access even to their own home or limited access to a bathroom. That increases the risk of taking a fall, reduces also the patient's interest in really taking care of activities of daily life. So often when patients comes, either to the PCP office or to the hospital, those very barriers that I just alluded are often perceived as member is non-compliant or patient is not compliant, the patient is a poor historian, when in reality is that there are barriers that if removed, then patients can engage directly in their own care coordinations of the services. I believe as part of the resources that we will share with the group after this presentation, there's a video that will speak more in depth on this from a patient's perspective and also provider perspective. The one more thing I want to touch quickly is the role of housing insecurity impacting age-related conditions. And we know that housing can affect many aspects of a person's life. I want to highlight two conditions specifically, just to get my point across. Let's think about a diabetes patient or a COPD patient, with one who is insulin dependent, the other has an oxygen concentrator. Think for a moment how not having a permanent safe shelter plays a huge factor when it comes to storing medication, having a healthy diet, and then really understanding what patients have to face on a daily basis. And that is the priority of investment. This is where members have to take a decision. Is it the medication of my shelter? Is either food or the shelter? And this is a reality happening with our members. I think, first of all, we need to really understand what those barriers are, and our intervention should be a direct response to address not only the housing insecurity, but the barriers around it.
Thank you, Kobe. Appreciate it. Keith, when we think about folks who are homeless, what are some of the healthcare needs these folks have? How do you go about thinking about street medicine or transitional services for them?
Thank you. I'd like to comment on points that Kobe and Kathy have raised that I think are incredibly important. As an administrator, my favorite text messages to get are pictures of people getting their keys and moving into their units. And it gets me every time. We've housed 130 people this year just out of this Street to Home project. And I mean, I don't get texts for everybody, but it's a wonderful moment that often quickly dissipates into a lot of anxiety and a range of emotions and needs. So we see the elation quickly dissipate into those challenges. Namely, what do I do with this apartment while I know that people that are closer to me than family are sleeping in 10 to 15 degree weather? And how do I say no to people that want to come crash with me for a bit? Or there are a lot of things that we have to do on the front end before folks even get housed, which has been such. I mean, the cottages have been a godsend for that, because we've been able to do a great deal of engagement and planning before the person transitions into a permanent supportive housing option. But let me just get into some of the service elements that we look at putting people into before they even set foot into their unit. So the first thing, we love acronyms in Massachusetts. We have the Community Support Program for people experiencing chronic homelessness, and we have recovery coaching. And these service elements are billable to Mass Health, which is interchangeable with Medicaid. And we also have a nurse manager and a regional director of services who is a nurse. We offer medication-assisted treatment and mobile psychiatry, as well as the care and stabilization elements of trauma-focused modalities of treatment. But it's absolutely paramount that we bring supportive services to the person. We saw evidence of this with, I think this was illustrated in that statistic I gave previously when I spoke around the level of engagement with community, with primary care physicians in the community, as opposed to needing to be, only tethered to street medicine components vis-a-vis the Boston Healthcare for the Homeless. Oftentimes, I guess the best analogy I can think of is if you're starting a campfire, it's almost like bringing these support services into the home is the kindling and the small piece of newspaper that you'd use. And then the goal is for it to catch fire. And when it catches fire, the work becomes magic. It becomes less about providing medical and behavioral health supports, as opposed to becoming more transformational, where you're helping the person carve out a life and filling it with things that they have been passionate about in the past, but have been long dormant, secondary to having to contend with unsheltered homelessness and the myriad of complexities that come with that.
Thank you, Keith. And we've sort of talked a lot about what the opportunities are, the impacts of housing insecurity and homeless are, where the various places we can intervene. I'd like to, if we could, move toward thinking about what are some of the innovative programs and experimental approaches that have been tried and tested both locally and nationally. Maybe you could share some of the results that we've seen, and how can we partner with local governments, agencies, and community organizations to be effective. And I'll start with you, Kobe, about the community partnerships and sort of preventive approaches used to keep people housed.
Yeah, no, absolutely. I think I want to begin by saying that housing has become this complex issue and system to navigate. And the level of complexity might vary from state to state, but nevertheless is complex nationwide. And I think something that we know is that there are many stakeholders and organizations that are trying to fix the same problem. And at times that's in collective, but I have to say disjointed efforts can simply create duplications in many instances. So with that in mind, what are some of the best practices? I think this is where community partnership comes into place. Knowing that, there are many community-based organizations working with our same patients, and if the question is, there a way that we can partner, given that we're working towards the same objective? I do have to say that it will require a shifting in mindset from perhaps being I'm going to use this very colloquial phrase, being a jack of all trades, right? And really shifting to becoming that it takes a village mindset. There are ways in which we're doing this here at the local state level in Massachusetts. The CCA has partnered with Hebrew Senior Life, which, for the sake of this particular partnership, they are a senior living organization that provides supporting housing to individuals, while CCA continue to provide both the case management and the care delivery for our same patients and members. What that has allowed us to do is really to deliver the right care at the right time, at the right place, where both organizations work collectively with residents and members that are not really concerned about their housing insecurity. Another partnership that CCA over the years have developed is with another local organization, the Hearth. This is a housing program in Massachusetts. And really, this partnership has allowed us to place many CCA members and patients into permanent supportive housing. And that allows CCA and the Hearth staff to really monitor and address any medical, social, behavioral needs of these individuals. Again, keeping in mind that once they are permanently housed, they don't have to pick and choose whether is it more important my rent versus my medical appointment. That is totally removed once they are permanently housed in some type of supportive housing. The way that partnership works, it's each member is assigned to a care partner, which is a case manager, a nurse, or a behavioral health clinician, and they will conduct an assessment on the member's social, behavioral, and medical needs. And if there is an identified housing insecurity need, we are going to refer to one of our community health workers. They will begin to work with those members and patients to understand better the story behind the housing insecurity. And if they meet criteria for eligibility, they will refer to this housing program. In the other spectrum, I also want to touch on the preventive work. And I think we have, all of us here, Keith and Kathy, we have spoken about the impact of housing insecurity in healthcare in general. But, some of those impacts can also be preventable. But for that, we do need to take a preventive approach. So the way we are doing this here at CCA, number one is we have increased access point for conversations around patients' social needs, included but not limited to housing. We looked at the different member touches and we asked ourselves, do we have an opportunity when we are engaging with members to really understand their non-medical needs? We have an interdisciplinary approach because we understand that sometimes, although community health workers are the subject matter expert on SDOH, we understand that at times the best person to have those conversations with members can be the nurse or the BH. It all depends of who is the most connected with the member. So we are equipping our workforce so that they can have that level of conversation and really shifting from this screening mentality, checking the box, to more a conversation with member. And this is huge because there is some sort of a stigma that comes when disclosing this level of personal information. So, and it only gets worse when we are just checking the box. So we want to be more empathetic and we want to have conversations with our members. Early on, I alluded that I was going to touch on the housing education component. And we did some work a couple of years ago looking at the different housing workshop programs within Massachusetts. And we were trying to understand what is it that they offer, why are patients and members not attending, and what is the impact of those programs. And what we learned was that it was unclear to patients and members what those programs offer, which, it highlights another barrier. It's not enough just to give a flyer, go and attend this program. The issue of access, which was a huge component. Not every patient has the same conditions. Therefore, we need to be able to provide equitable access to this program. And then the actual content and the level of support was not being tailored to the individual needs. So based on those observations, we decided to create our own workshop. And this workshop, the best way I can describe it very, very rapidly is it requires pre-work before the workshop. And this is where we understand the individual need of the member and the patient. And based on that, we are going to put together a housing research package and guide really tailored to that individual. By the time they come, everything that we have to offer to them is directly related to their specific needs. They get the individualized support when they come in as well. And with this approach, this is really helping us to effectively provide support with individuals with housing insecurity.
Thank you, Kobe. It's obviously housing and achieving housing for individuals is a complex venture. Frequently, there are multiple ways these things are clearly coordinated, as you've talked about, Kobe, using a variety of community partnerships, but also there's a variety of funding resources. And so, Keith, maybe you can talk with us a little bit about how you have worked with bringing together multiple different areas of funding to try to get to one result for a project.
Sure, I'd be happy to. So starting this past August 2021, sorry, we started working with the city of Boston and an agency called Clutch out of Houston, Texas, to operationalize a initiative called Street to Home. So what did this look like? We basically combined national, state and regional municipality partners and stakeholder agencies around a shared goal of trying to house 250 individuals experiencing chronic homelessness in the city of Boston. The cohorts were separated into Mass and Cass, which you saw pictures of in the video, as well as citywide folks. So what did we do? There's an assessment out there called for coordinated entry, and coordinated entry is basically the coordinated entry assessment is it quantifies your behavioral health, your medical complexity, duration of homelessness, and gives us a score. And that's basically how subsidies within continuums of care are disseminated. We had for lack of a better phrase, a strike team that went out to the Mass and Cass area at 6 o'clock in the morning every Wednesday for a period of time. And we completed 200 of those assessments. And then we had what we called a massive match event virtually. We matched a significant number of people to housing subsidies, and then began the process of getting vital documentation so that the subsidies could come to fruition. And there were some challenges with that, given that there was a couple month wait to get Social Security verification. So we worked very closely with partners at the state and federal level to expedite the process of getting Social Security verification forms. And the Commonwealth of Massachusetts also set up an RMV, a Registry of Motor Vehicles, pop-up satellite site right in the area that you saw in the video to make it easier for people to get the photo identification that is needed as a prerequisite to getting the housing voucher. So by the time a number of folks got to the Shattuck Cottages they already had not only their subsidies in hand, but photo identification there. And we combined a lot of different resources. We have the statewide PATH grant, which is hybrid funded between the State Department of Mental Health and SAMHSA, ESG funds through our State Department of Housing and Community Development. The Shattuck project itself, CCA subcontracts out to us and provides us with funding for stabilization services. We also have Mass Health, which funds our case management and recovery coaching programs. The Massachusetts Housing and Shelter Alliance, which funds our enhanced navigation and stabilization team, as well as the City of Boston. They covered a lot of our ancillary expenses that came up. And we were able to do a lot of really creative things, like bridge people for 6 to 7 months by paying their rent while we went through the process of getting the voucher in hand, and as well as transitional hotel stays.
Thank you, Keith. It's been really helpful. There's a lot of work going on in Massachusetts and Boston, but I'm interested, Kathy, in what are you seeing nationally?
Thanks, Rob. So, in addition to, I just wanted to key off of this. Great, I'm following Keith. The necessity of braiding together funding. It's always going to happen no matter what. But I want to point out the big role that states can play, Medicaid programs can play in providing their funding and their supports. And so we've seen this already in a handful of states, Massachusetts, of course, as Keith mentioned, Minnesota, Washington. Washington State has a program called Foundational Community Supports that has been running for a while that provides some of these tenancy sustaining services, tenancy supporting and sustaining services. And there's also a handful of states that have things in the works with CMS to be approved. But I want to spend a little bit of time talking about California because they have a very recently, probably the most recently approved Medicaid 1115 waiver. There's other mechanisms or vehicles like 1915I state plan amendments. But, kind of since this isn't a Medicaid 101 class, there are Medicaid vehicles, a variety of different ones, including waivers and state plan amendments and managed care contracts, states working with their managed care plans to put requirements into the managed care contracts to support providing care to people experiencing homelessness, to support their housing needs as they are becoming housed. And so just real quickly on California, the project is called, or the initiative is called CalAIM. And what is unique is there is a specific population of focus, as the state calls it, which is people experiencing homelessness. And some of the kind of key services available through the CalAIM program include some enhanced care management, which of course is very relevant and important to people experiencing homelessness in order to help provide them the care that they need where they are, and when they need it, as well as what you may have heard of as in lieu of services. In California, they call them community supports, but they're basically optional in lieu of services that managed care plans can provide to support individuals in their plan. And so in California, this includes things like housing navigation and pre-tenancy supports, medical respite, medically tailored meals, sobering centers, a variety of different resources that could be available to their wider health plan population, but are also, very important for the population of focus of people experiencing homelessness. I also just wanted to take 1 second. I know we're going to put up a slide here of some of our resources, but I also wanted to mention federally, at the HUD level, it's really exciting, and we're going to include a link in this slide. HUD has put forth some of the first ever dedication of federal housing resources explicitly for people experiencing unsheltered homelessness, and prioritizing communities who have partnerships with healthcare providers, Medicaid agencies, et cetera. And so it's a great opportunity to bring together the healthcare resources to the table with housing providers, which is something that we've been talking about, through this whole presentation. In addition, there's also 4,000 new housing choice vouchers nationally and over $330 million being given to communities COCs as an important opportunity to expand, these healthcare partnerships with housing providers. So if we can throw up that slide, I think, Rob, you're going to close us out, but the slide includes some of the resources that Kobe and Keith and I have all referred to today.
That's great, Kathy. And I think, Keith, you had a couple of points, 30 seconds that you wanted to share with folks.
Sure. I just neglected to mention that since August of 2021, we have housed 130 individuals by combining all of those service elements that I referenced. The Commonwealth was very flexible and supportive and allowed us to redeploy all of our staff within those service elements, all 25 plus, to this shared goal. And we're providing stabilization support services for 98 people at this point. And our next step is to work with accountable care organizations at the executive level, including our wonderful partners at CCA, around providing more specialized services into homes, including occupational therapy, physical therapy, and healthy meals and other supportive services. Thank you.
Thank you, Keith. Thank to all the panelists. And we do have a resource guide that we would like to share with everyone. So thank you for joining us today.
Thank you to our speakers for that wonderful discussion. We'd like to once again thank the sponsor of this session, Commonwealth Care Alliance. For more information about Commonwealth Care Alliance, please visit commonwealthcarealliance.org. Thank you so much. Enjoy the rest of your conference.